what we would do with Jack initially, so, we'd initially do some spinal assessment. But I think because he's coming to me as a pelvic pain patient, the spinal assessment that I would do will be quite a small component compared to what you would do in a low back pain patient. And one of the reasons for that is we want to really, in our assessment, focus on a bit more time on some of the pelvic health. So just to tell you what we would do in terms of spinal assessment, I would have a good look at Jack's kind of lumbar spine movement. So doing his kind of, flexion, extension, side flexion. I would want to have a look at his thoracic spine. And the main reason I want to look at his thoracic spine is in a minute, we're going to see what his breath pattern is like. And obviously for that good belly breathing, abdominal breathing, you need kind of good thoracic expansion. And also what I want to do is have a general look at his hip movement. So that's just doing his, hip flexion, rotation. What you find with some of these pelvic pain patients is they can, particularly the patients who've had lots of pain for a lot of time, is they can get deconditioning. So if Jack's had pelvic pain for 2 years and he's had to give up all his training and he's not playing football, he's not going to the gym, it is likely he may have developed maybe some secondary lumbar spine, hip stiffness, thoracic stiffness. So that's what some of the musculoskeletal assessment looks like, looking at lumbar spine, thoracic range of movement, hip range of movement. When we start to get into a bit more of the pelvic health aspects, what you find with pelvic pain patients is that they can have a lot of abdominal muscular referred pain. So patients with back pain, if I palpate with a patient, I'd have this lifted up, but we can leave it down because we're on the camera. So if I were to palpate into that kind of rectus abdominis, that right and left rectus abdominis. So if I palpate in here with Jack, so we could find maybe that linea alba midline, find that left rectus. So if I were to palpate into that muscle belly, that should feel, relatively soft, comfortable. And it might feel like a bit of light local pressure. And what I'm really doing is just going into that rectus right and left. What you find with some of the pelvic pain patients is they get some of that abdominal referred pain. So particularly if it's, let's say Jack's symptoms are very left-sided, so the side that I'm on, and Jack's getting maybe left-sided perineal pain, so in that soft area underneath. He's getting left-sided scrotal pain, and he's getting maybe left groin pain. So he's very much left unilateral pelvic pain. So when I palpate into that left rectus, what I may feel is real areas of resistance. And as I press in, what's common is so I'm feeling resistance. I'm feeling that there's a little bit of local kind of spasm contraction there. And sometimes what the patient reports is when you palpate, they're getting either increased symptoms or reproduction of those symptoms. So I could press in here and this might give Jack some left-sided scrotal pain or maybe left-sided perineal pain. But if I do the right side, I'm not going to move to Jack's right side or the people will wrestle me to the ground. Whereas if I do the right side, it feels very soft, asymptomatic. And why does that happen with pelvic pain? The reason that it's thought that there's a bit of maybe visceral referral mechanism there, or also some degree of central sensitization. So you're getting a little bit of allodynia or hyperalgesia.
So when you're palpating, are you feeling a sort of a general resistance there, or is it more of a trigger point type resistance?
It tends to be probably more that kind of localized trigger point resistance.
Right. Okay.
But what you are looking for is this either increasing those pelvic symptoms or is it producing them?
So I may be getting ahead of myself here because you may be covering this, but we've done, as you and I discussed before we went on air, we've done a number of trigger point related dry needling courses here. If we were to needle that trigger point, are we likely to address that? Is it a referred pain pattern?
Yeah, and this is where, you know, all the musculoskeletal people listening and the people who've got either good hands, they can do good soft tissue work, can start to treat that, or the people who've got dry needling skills. So that's where you can start to target some of this pelvic pain without having to go into that perineum, without having to go internally.